Welcome, everyone, and thank you for joining today's webinar. We are thrilled to have Dr. George Zanonos here to share his expertise on the topic of minimizing the burden of trigeminal neuralgia treatment. Whether you are directly impacted by facial pain or simply interested in learning more, we're grateful that you've taken the time to join us this afternoon. My name is Melissa Bombeck, and I'm the CEO of the Facial Pain Association. Before we begin, I'd like to share some exciting updates from the FPA and go over a few housekeeping items. The Facial Pain Registry is live. This is an excellent opportunity for patients around the world to strengthen their voices and provide critical information about their experiences living with facial pain. By contributing your story, you play a crucial role in helping researchers, doctors, and policymakers gain deeper insights into the true impact of facial pain, ultimately paving the way for better outcomes. Visit the FPA website at www.facepain.org to access the registry. If you have any questions or trouble once you begin the registration process, please contact our office or send an email to registry@facepain.org. We are also finalizing the video recordings from our recent in-person conference that took place in early June in Minneapolis. All conference attendees will have free access to the recorded sessions. For anyone who wasn't able to attend but would like immediate access to the videos, they will be available on our website for $35. And starting in October, we will release one presentation per month as part of our conference video series. At that time, the videos will be available to view at no charge. Now, to go over a few housekeeping items. If you have any questions, please use the Q&A feature at the bottom of your Zoom screen. We will have a dedicated Q&A session at the end, but please feel free to submit questions throughout the presentation. We encourage you to connect with other attendees using the chat feature. Today's webinar will be recorded and available on our website and also on our YouTube page in approximately 1 week. Now it is my honor to introduce Dr. Zanonos. Georgios Zanonos joined the University of Pittsburgh Department of Neurological Surgery as an associate director of the Center for Cranial-Based Surgery in July of 2019. He is one of a handful of neurosurgeons to have completed 2 fellowships in skull-based surgery, one focusing on endoscopic and minimally invasive approaches at the University of Pittsburgh, and another focusing on complex cranial neurosurgery and cerebrovascular neurosurgery at the University of Miami. Dr. Zanonos completed his internship, residency, and chief residency in neurosurgery at the University of Pittsburgh from 2011 to 2018. During this time, he received several distinctions and awards, including an award for achieving the highest score in the nation on the American Board of Neurological Surgery written exam. He states, "I understand that having to see a neurosurgeon or needing a neurosurgical procedure has to be one of the most frightening experiences in someone's life. My goal is to always provide the best care possible for each and every one of my patients, one that utilizes the latest technologies and techniques, and one that is founded by evidence-based medicine. The same care I would want for my family, my friends, or myself. Putting myself in the patient's shoes and understanding the unique difficulties they are facing is always step one." Again, we are thrilled to have you here and hope this session is helpful for you. Without further ado, let's get started. Dr. Zanonos, please take it away.
Well, Melissa, thank you so very much. I think I thank you for this wonderful opportunity. I'm just going to share my screen as we speak here. Please let me know if you can see everything okay.
Yes. If you want to, yep, there we go. It's perfect.
Excellent. Yeah. Well, firstly, I'd like to congratulate you for leading this effort. I think it's wonderful for patients to have a resource to educate themselves. I do think it's paramount for the patients to be the advocates for themselves and their families, and really understand sort of the nuances of the disease they're facing, and try to ask the appropriate questions where seeking care, and ultimately, hopefully, have the optimal outcome that they deserve. And that's sort of part of the focus of my presentation today. Hopefully, would like to make this an interactive presentation, and hopefully we'll get some questions answered from the audience afterwards. But the point being is, what can we do to minimize the footprint of the treatment of trigeminal neuralgia? Everything we do is a double-edged sword, and there's some benefits and there's some shortcomings of everything we do. So what I'd like people to understand today and take away from this is, what are the sources of morbidity that are associated with the treatment of trigeminal neuralgia? This is something that is treated across the board. It is technically not very challenging, so I would say like multiple people attempt to treat this, whether they do one a year or just a couple a year. But the truth is that there's several nuances that are associated with these different management strategies. And choosing the right approach is not always straightforward. There are also many, many ways where we can decrease the footprint of what we do, reduce the morbidity, and increase efficacy and patient satisfaction. And I do apologize ahead of time. There are some videos from surgical approaches, etc. They are not too gruesome, but I do feel that they're important for patients to understand what are the options, what is involved, what they're going to go through, what are the pros and cons of each one. We're fortunate to be at a place where there's perhaps one of the largest experiences in the world in treating this disease, starting with Peter Janetta, who was one of the first chairmen of the department, and actually popularized the microvascular decompression for trigeminal neuralgia. And since that time, our center has become a center for referral for these patients, and so we see many patients with trigeminal neuralgia. With over 22,000 estimated patients treated over the years, there's many things that have been done to try and minimize the footprint of what we do. Everything starts, of course, with the correct diagnosis, and that's not always straightforward. It also comes with choosing the optimal treatment strategy for each patient. Not every patient is the same. There are nuances, again, in choosing the appropriate treatment for each patient, but also setting expectations. And what I'd like to really go into detail today is some of the technical nuances for the surgical options that render what is already perhaps a minimally invasive approach an even more minimally invasive approach, which minimizes the pain, the hospital stay, and the recovery time. So again, the correct diagnosis. Trigeminal neuralgia is perhaps one of the most excruciating pains that a human being can experience. It's no surprise that it was coined the suicide disease before we had optimal treatments for it. People were jumping off the windows just to get rid of this disease. It has to be in the appropriate distribution. The trigeminal nerve has 3 branches, as we see here. So it has to be in the distribution of these branches. It can't be like in the back or somewhere else. It has to be these branches. It can be idiopathic or primary, what we call that it happens without a secondary cause, or it can be because of something else, such as a tumor, demyelinating diseases such as multiple sclerosis, or vascular pathology such as arteriovenous malformations or dural AV fistulas. And then we have to have treatment strategies that are geared towards treating the secondary causes as well. Perhaps one of the most important things that I want to know when I'm treating a patient with trigeminal neuralgia is to understand what is their pain like. And in general, the 2 extremes are what we call a typical or type 1, which is this electrical, sharp, lancinating, lightning bolt kind of pain that comes in for a very short second and goes away. And it can be a period of time where people experience many of them, but the pain is not constant. And that's why we call atypical pain or burning, dull, continuous pain. And this pain is much harder to treat. The first one, although it's much more excruciating, is actually much easier to treat. And of course, there's the people in between, what we call it type 2A or mixed pain. And then setting expectations is critical because this type 1 pain we can treat effectively. Some of the burning pain that can happen as a prelude or as an aftertaste of this electrical pain can still respond well. Or sometimes patients have their electrical part of the pain masked because there are medications, and these can be treated well. But when people have continuous burning, dull pain without much electrical pain, that's a much harder disease to treat. So setting the expectations and helping patients understand what to expect is critical. This is not to be confused with other neuralgias that can cause facial pain, such as occipital neuralgia that happens at the back of the head, and glossopharyngeal neuralgia that is associated with pain in the ear and the throat, and then genicular neuralgia that's only in the ear. We have to make sure that this is not coming from dental disease or dysfunction of the temporomandibular joint, or is referred pain from someone's neck. So step one, many times with my patients, to help them understand what is going on. And I feel a good parallelization is to see that the nerves are essentially like cables. Many people understand how cables transmit electricity. They have this metal wire inside that transmits the electricity, and that's what the nerves are, the neurons. And we also have this covering, which is this plastic part around the cables that prevents them from spreading from one to another. And this is the myelin sheath that is actually different inside the brain and outside the brain. We'll talk a little bit more about it. But that's what keeps the signals from each neuron spreading from one to another. Now, the only way that the brain understands what is happening in the periphery is which cable is transmitting a signal. If a cable is associated with pain transmitting a signal, then our brain understands that there's pain going on. On the flip side, if there is somebody lightly touching you on the face, there's a different wire that is activated, and that's what our brain understands. However, if there's an issue where these signals get mixed up, or some of the neurons are firing on their own, then the brain is thinking that there's something that's inciting pain on the face, where this is not in fact true. And there's two ways that I like to explain to patients how this is happening. If the actual cable is damaged, which is not very common, but if the actual cable is damaged, then that's much harder to fix because nerves don't fix themselves very easily. And this is what we call neuropathic pain. When people have dental procedures that were botched, etc., or they have permanent pain, this is the kind of pain that they have. It's more dull, continuous, achy. The sharp pain usually happens when they're shorting within the nerve in a way that the signals go from one to another. So it's more the plastic that is affected. And then the signals get short. And that can actually fix itself. So the myelin sheaths around the nerves can fix themselves. One of the most common reasons that these myelin sheaths are degraded and they don't function well with signals going from one nerve to the other is because an artery is actually pushing on the nerve. As we grow older, just like our skin gets a little bit more lax, our arteries get a little longer. And because they're in the skull, they have nowhere to go, so they create these loops, and then these loops can start pushing on the nerve. Every time our heart beats, this deforms a little bit, and it kind of pushes very lightly on the nerve, but heartbeat by heartbeat, this actually starts wearing down those coverings. Now, our body, like I said, can repair those coverings much better than it can repair the nerves. But our heart never stops beating, so it never catches up. Sometimes it does catch up a little bit. Sometimes that explains why people go a little bit into remission. But as our arteries get longer and longer and the push is harder and harder, this inexorably becomes harder to control, and people develop this recalcitrant pain. So what are we looking for, again, when we're evaluating for trigeminal neuralgia? Again, is it primary or secondary? Is it some tumor that's there that we have to deal with? And we show some examples later. But is there any history of damage to the nerves? For example, dental work or herpes zoster infection or a trauma? And that, again, helps set expectations. What I want to hear to know where I can help someone is if their pain is at least to some extent typical, if they have at least some sharp pain. That tells me that there is damage to the myelin sheaths as opposed to the nerves themselves. And that actually is treatable. And again, it helps me set the expectations. What are the triggers? Do people remember that? This is such a bad experience that people often remember that when it started. And that's usually more typical of the type 1 or classic trigeminal neuralgia. One other thing that we want to see is whether they responded to these medications. There's a family of medications that prevent the nerves from firing as much, such as carbamazepine. That's the most classic medication that we use. But beyond a therapeutic indication, it's also very useful to know if they responded. And it's really important to kind of drill into what happened. Did people, if they say they didn't respond, why didn't they respond? They actually, the pain got a little bit better, but they had a rash, or they were sleepy, or they were unsteady. All those things are important. Finally, so if there is some typical component to the pain, then I know I can help them. And then the next question is, do they have a vascular compression? Is there an artery or a vein compressing the nerve? Now, when there's an artery, the compression is usually more intense. And by removing the artery away or moving it away, usually, the success rate is extraordinarily high. It is true still with the veins, but the success rate is not as high as with the arteries. And also it's important if there's just mere contact or is there significant compression. If there's significant compression, even better. Then I'm more optimistic that people are going to get better. If there's just contact, sometimes I may advise them that I may do an internal rhizolysis of the nerve as well when I'm there. That may increase the chances of having some numbness. But if you're just moving the artery or vein away, the likelihood of numbness is pretty minimal. So everything starts, again, with stepwise progression. So if someone has trigeminal neuralgia, they started on medication, they're doing very well, they have no side effects, they have no pain, you can't make it better than that. And many times surgeons are incentivized to actually do procedures, but the right thing to do is actually to do nothing. So the thing that has the strategy that has the less footprint is actually continue medical therapy. Now, once that stops working, if there's vascular compression, I very much urge people to have a microvascular decompression. That's a very effective treatment that can get them off the medication and then usually has very long-lasting results as well. However, if they don't have vascular compression, and we're looking at some of the ablative options, I may push the patients, if they're managing the pain, to deal with some of the pain before we actually start doing any of these procedures, because all of these procedures, other than the microvascular decompression, they cause mild damage to the nerve. Some of them less, some of them more, but they all work with the same way. They work by causing some mild damage to the nerve to urge it to kind of fix itself. That's at least how we think it works. So, but there's a price of causing mild damage to the nerve every time we do this. And because they're not going to last forever, these ablative options, not the microvascular decompression, we kind of have to use them when it's necessary. And there are also non-ablative options that tend to work a little less, but they also have less of a price of nerve damage. So again, the gold grail is the holy grail is microvascular decompression. If someone has vascular compression, that is close to 100% effective, long-lasting results many times for someone's lifetime. There's immediate resolution of the pain, is the least likely to cause numbness because it is not associated with any nerve damage. People can get off their medication over a week. It's an overnight stay, not in an ICU, but what we call hotel status. Is extraordinarily effective. But how do we make this effective and less invasive? There are multiple nuances in how to do a microvascular decompression that I think make all the difference in patients' experience and potentially complications. First of all, we've devised a way to do this procedure through just over an inch incision. That's 3 centimeters behind the ear. In order to do that, you do have to use image guidance. I've met a lot of surgeons that you don't have to use this. This is a nothing procedure. But in order to minimize it and be very exact with it, using image guidance makes all the difference because you have to be very exact. Just like everyone's eyes are not shaped the same, or mouth, not everyone's exact area to enter is the same. Also, we devised a way that we actually don't disrupt the muscle. We don't cut through the muscle, and I'll show a video on how we do that. But by avoiding cutting through the muscle, then you actually decrease pain, and you also decrease the atrophy that's associated with it. So people don't have a divot at the end or in the length of time. I also very much avoid burning the tissues. I try to minimize the cautery, especially on the skin, that creates larger scars, etc. One thing that I can't emphasize enough, and again, I'm a skull-based surgeon at heart, so I deal with this area, whether it's microvascular decompression or something else, almost every day, is having the optimal exposure. And I will explain what I mean by that. There are 2 veins here, what we call the transverse sinus and the sigmoid sinus. And in order to have an optimal exposure, you really have to go right in this area. And that's what we're trying to find with image guidance, right in this confluence that they come together. If you can imagine, this might be the trigeminal nerve, this yellow line. And this is a CT scan with contrast. And this is that vein that we talked about. It's a pretty large vein. It's what we call the sigmoid sinus. All this is part of the brain that's called the cerebellum. It's the coordination part of the brain. And this nerve comes off the brainstem, which is a very important part of the brain, as most people know. So in order to get to the area where the central myelin sheath transitions to the peripheral, and that's an area of weakness of the nerve, and usually the area of compression, we have to make an opening in the bone and go around the cerebellum to reach that area. Now, there are also little veins in the bone, what we call emissary veins, and that makes many people scared to go close to this vein. There are very safe ways to expose this vein for people that deal with it all the time. So one rookie approach is to make the opening here, way here in the back. We're trying to avoid this vein, have nothing to do with it. We don't want to see it. We don't want to see it with this honeycomb of the cells, what we call the mastoid air cells. So they make the opening way back here. This is, in a way, brain surgery, but it's not supposed to be brain surgery in the brain. It's supposed to be around the brain surgery. So we want to get in the skull, but work around the brain to go where this nerve is. Now, there are a few problems with this approach. One of the problems is that you have to retract the cerebellum. You have to push the cerebellum back to go back to this nerve. So that creates bruising in the cerebellum. The other issue is that you can't really see the entirety of the nerve or exactly where this is supposed to happen. You see the front of the nerve, which is usually not the area of the problem. So what has to happen is actually what we call an expert approach is go close to this vein, which again is a very safe thing to do, to be able to go around the cerebellum, not have to retract the cerebellum, and see the entire length of the nerve and see everything that's pushing on it. And then very gently kind of move them away. This example of a patient that I treated that unfortunately followed a very unfortunate course. It started with an attempt to do a microvascular decompression somewhere, which again, the opening in the bone was way in the back. So someone had to really push on the cerebellum. You see this white thing here, that's dead part of the cerebellum. That's cerebellum that was bruised and died. You also see here that because they cut it exactly through the muscle, it created this divot here in the muscle, and that's something that's cosmetically disfiguring. This patient also had about a 10-centimeter incision in order to do all this. So they did a 10-centimeter incision. They created this burr hole like way in the back, bruised the cerebellum. And one of the worst thing is that they couldn't actually see the area of compression. This is a trigeminal nerve. This is the area of the actual vascular compression where it's coming out. And that's the area of the problem. And this is where they put this little cushion, the Teflon. You can see it's very clear that they couldn't see at all exactly what's happened. So again, this is a relatively simple procedure, but there are nuances to it. And unfortunately, this patient went on, it was told, oh, we did try the surgery, it didn't work. Then tried the lesional procedure with a glycerrhizotomy, that of course didn't work. And then went on to have not one, not two, but 3 gamma knife treatments that didn't work. The patient still had compression, still intractable pain. So we did an appropriate craniotomy. And we didn't even have to open the entire incision. We used a fraction of the incision, moved the artery away, and she's very happy. Another important thing is, having adequate neurophysiology. One of the things at risk here is hearing. And you have to be able to monitor the hearing during surgery by what we call the brainstem auditory evoked potentials in order to do the surgery safely. This little tube here is actually providing signals in the ear that create these waves all the way up to the brain, and that help us understand if we're retracting a little bit too much on this nerve. This nerve can be sensitive. But you can't really do this surgery without this. It will be malpractice to do this surgery without having this. Now, the issue is that some of the older machines only use a certain frequency. But as we get older, we develop high-frequency sensorineural hearing loss. So many people, as they get older, they don't have a very good signal. If you don't have a very good signal, then you can't have the surgery because we can't monitor your hearing, even though you're not deaf. So in having appropriate neurophysiology that allows for multi-frequency brainstem auditory evoked potentials and appropriate monitoring of this makes more people eligible to have the appropriate treatment, have a microvascular decompression. And we do this preoperatively in all the patients to make sure that we have an appropriate response. That would be really bad to figure this out while we're doing the surgery. And it's not an unusual thing that happens. You don't hear about it much. But people go in surgery, that people can hear okay, so they expect them to have brainstem auditory evoked potentials, and they figure out that they don't have them actually. And they're not deaf, so they're putting their hearing at risk. Another thing to do, this is a surgical video, but there is a fissure in between the 2 lobes of the cerebellum that we can follow in order to see the entirety of the nerve. I tend to sacrifice no vessels going in. This is a trigeminal nerve. And then you see here, by exposing the entirety of the nerve, there's actually 2 vessels that are pushing on it. We're using sharp dissection that allows us not to bruise the nerve, not to move it around in an untoward fashion. But if you see the entire length of the nerve, then you're able to do a complete decompression. Many times there's more than one inciting issue. Now, these are the coverings of the brain. And it's important to get a watertight closure. Many times we devise this way of opening along these veins and then allowing this covering of the brain, what we call the dura, to actually be in contact with the cerebellum. That one protects the cerebellum, but also keeps it wet. And that allows us to close it without using foreign implants. These implants can often create issues with reactions. So we don't have to use them. We had to use these foreign implants less than 1% of the time if you open in such a way. One of the very important things is also use of the artificial bone or bone cement. We don't use plates or implants. These are metal plates that can be put here. Skin doesn't like healing of these plates. And then these plates also don't recreate the normal anatomy. They create divots. They can actually break through the skin. They cause the skin to thin out more. By using this bone cement, the cosmetic result is far superior, and it looks like it did before. Even more importantly, it decreases dramatically the chance of any of that brain fluid leaking out. By sealing that once it's set, there's a pretty much almost like a 0% chance that this fluid is going to leak out. And that's very important and takes us to the next step, because it allows for the muscle tissue to be closed in a more relaxed fashion. So here's the muscle tissue, and then we put it together. But we don't have to make it super tight, because surprise, surprise, if you close the muscle real tight, then it actually feels very tight after the surgery. And very tight muscle closure and tightness in the back can keep you here in the hospital longer. It increases the pain and increases dissatisfaction. I like to use absorbable sutures, so nothing needs to be removed. People can travel back right after the surgery if they're coming from another state or even in another country. It also avoids uncomfortably removing the sutures that nobody likes. And also it provides a very good cosmetic outcome. So how does all this work? I'm just going to run a video of like the entire thing. So these are the two veins, the transverse sinus and the sigmoid sinus, and we mark this with neuronavigation, exactly what those are. We use local anesthesia to avoid bleeding in the skin, and I don't use cautery much in the skin that burns the follicles. That allows things to heal a lot better. If you burn things, they just don't heal as well. Now then, the goal is to cut not through the muscle. By doing this dissection, it allows it to go around the muscle and create this little flap, which allows us not to cut in the muscle itself. So we just mobilize the muscle. And then with this way, the muscle doesn't atrophy. We do have to use a little cautery to disconnect the muscle as it's attached there. Now, the next step is to create this opening. In the opening, again, we use neuronavigation to see exactly where it's supposed to be. And the goal is to expose at least partially that vein. This is under significant magnification. Again, the whole incision here is less than it's almost just over an inch. But here's that one vein and the other vein. And then we go ahead and open the coverings of the brain. So we open it along these veins. You see the cerebellum is already kind of relaxed. We do use medications to help with the relaxation. We even retract some of this vein here forward. Now it increases even further our angle of attack, so we don't have to retract the brain. The brain is very squishy. It is almost like a gelatin. So if you push on the brain significantly, it dies, like the example that we showed. So we have like a very nice corridor that allows for almost no retraction. We go through this fissure that allows us to see the entirety of the nerve. This is the nerve where it comes out of the brainstem and all the way up to the trigeminal ganglion. In this particular instance, I didn't have to use Teflon. I created what we call a transposition as opposed to an intraposition. So I used these leaflets of the brain, this layer that's called the arachnoid, to just mobilize this artery away and put a little bit of fibrin glue here just to hold it there. There's nothing wrong with using Teflon, as we'll explain, but this case was just a one that I thought we could do that in such a way. Then putting things back in a watertight fashion. These are the coverings of the brain. So you see this is nice and wet. If you don't open it like that, usually it tends to dry out because of the light of the microscope. And when it dries out, you just can't reach back there. If you can't reach back there, you have to use a graft. And grafts, again, can create reactions. But our goal is to recreate this closure with your own tissues, so we don't have to use a graft. And then comes this artificial bone or bone cement, which essentially is like sculpturing. Our goal here is to recreate the contour of the skull like it was before. So it doesn't create any divots, any protrusions. And now this is watertight. There's no fluid leaking out. So we can close the muscle in a really relaxed manner so that it decreases the pain. And of course, afterwards, absorbable suture and all the way in the top, absorbable suture. So this is cosmetically quite favorable. I tend to shave almost no hair. You see some of the hair here, and sometimes the residents don't like it, but I like to not shave too much hair. So does this make a difference? I think it does. Our median length of stay at this point is 1 day. Again, patients from other states can go home like 2 days after the surgery, and then we see them through telemedicine. There's been a 0% spinal fluid leak rate over the last 5 years. And the infection rate is way below 1% for any retrosigmoid craniotomy. So with that low of a complication rate, there's no issue for people leaving and going back home. That's what they want to do. Some other technical considerations. Does using the endoscope or the camera, is there any advantage to that? When you make an incision that's this small and the opening this small, this is the place that the endoscope was going to take. So there's no place for the camera and main instruments here. So you do have to make a larger incision. And I sometimes do an endoscopic procedure, especially when we're doing a geniculate neuralgia. But for most microvascular decompression, this is not necessary. It's kind of a gimmick. Same thing with the exoscope. The exoscope is it's a microscope, but you look on a screen as instead of like through the actual image. So that doesn't work any better either. One of the very legitimate questions is whether to use Teflon or not to use Teflon. The sponges that we use with a transposition versus interposition. And there's mounting edit, there's really no difference how to do it. We really haven't, again, multiple thousand patients here at UPMC. There hasn't really been an issue with using Teflon. So this is something that we routinely use for most patients. This is an example of an endoscopic procedure. This is how it looks like. So we found this nervous intermedius. This is for genicular neuralgia. Again, it can be used for an MVD as well, but it does require a larger craniotomy. This patient also had concomitant disease in the lower cranial nerves. When there's a very large artery that's pushing on the nerve, not just a smaller artery, sometimes we have to do what we call a sling procedure, where we pass this little sling around the nerve, around the large artery, and we have to push it away. This many times we have to do for hemifacial spasm, but I have had to do it for a very small proportion for trigeminal neuralgia as well. Of course, many times you have tumors that are the cause. There's a large acoustic neuroma, and then you just treat the acoustic neuroma. The pain will go away. Same thing with other kinds of tumors, such as an epidermoid cyst. There's an epidermoid cyst that's pushing on the trigeminal nerve. Again, you just treat the pathology. Same thing with this very large skull-based meningioma. Or tumors that are coming from the trigeminal nerve itself, what we call a trigeminal schwannomas. This is a procedure that we did in the more traditional fashion from the side. The patient still went home the day after the surgery. And then you want to be able to follow an approach where it preserves the nerve. We just did a case today, actually, in a lady that had a tumor, and we had to use a specific way to get there. because exactly the nerve was in between the tumor was in between us and the nerve. There are also other minimally invasive ways of getting there, what we call transorbital approaches to treat these tumors, where we go through a very small crease in the eye and then approach these tumors like that. So what happens if you don't have a tumor or any vascular pathology, and there's nothing touching the nerve? Then the next option is to go to one of the ablative options. And there are multiple options like that. One is this gamma knife procedure with this radiation. And I do this for patients that can go to the operating room, but in my experience, that's been the least effective. It can be effective, but it's the least effective of the ablative options. Radiofrequency ablation and the balloon rhizotomy tend to cause more numbness. The glycerol rhizotomy tends to be a little bit less likely to cause numbness or this dull pain that can be the byproduct of these procedures. So usually that's the way we would do it. It also does not require people to be awake for it, which is usually the case for radiofrequency ablations. Especially people with trigeminal neuralgia do not want something in their trigeminal nerve. It can cause excruciating pain. So to increase patient experience, to improve it, I do this asleep. It's not a full asleep procedure where you have full intubation, but people are asleep. And all of these procedures are unfortunately not a permanent fix. So we expect them to work for a while, but usually the pain does come back. So you want to use them appropriately. And that's another part of being thoughtful about it. If someone is doing relatively okay, has a few shocks a day, they don't have anything pushing on the nerve, the appropriate way to treat is continue the medications and not jump to one of these procedures, because they're going to need it again. And the more times that you do these procedures, the more risk for numbness and neuropathic pain. And generally, you can only do them a few times. We say 3 times. I've done it more than that. And there's people that had numbness even with earlier treatments. So they're very good. Glycerol rhizotomy is very good. These are our own data for short and intermediate pain relief, but not very good for long-term relief. You see about 50% of patients at around 3 years, which is not bad, they would have recurrence of the pain. That's 50%. People that had prior radiosurgery tended to respond not as well. Interestingly, also patients that were taking oxcarbazepine, which may be a signal that they had a little bit more difficult to treat trigeminal neuralgia. Another option is doing these injections, and something that we've been doing instead of putting glycerol, which abrades the nerve to some extent, is actually putting a steroid and an anesthetic. And if there's any kind of inflammation that's in the nerve, it can potentially cause some intermediate pain relief. But it's usually shorter lasting than the glycerol. That sometimes is appropriate for patients that we know are going to need a lot of treatments. For example, people with multiple sclerosis. So there's another option that we use that perhaps a little bit less likely to cause numbness or neuropathic pain, this dull, achy pain. And of course, we have options for trigeminal neuralgia. This atypical. If someone has just dull pain, this is a much more difficult disease to treat. So medical therapy is primary, nerve blocks, neuromodulation also has a role. Is never perfect, but it can be effective. In extreme circumstances, the division part of the trigeminal nerve, what we call a DRES procedure, which carries significant potential morbidity. So with this, I want to conclude so we can have some time for questions. But what I want to conclude with is that the treatment of trigeminal neuralgia is nuanced. And there are a lot of details. The devil is in the details, as with most things. And these details matter. And it's important for the patients to be aware of these details are to some extent to try and choose the appropriate provider and the appropriate center. It is important to have a center where you have the entire toolbox, that all these treatment modalities are available. And you don't go to someone that just does one thing. But it's important to go to a place where there's long experience, and experience comes with minimizing the footprint and making the whole experience more optimal and more enjoyable for the patients. So thank you again for everyone that logged in here and is participating. This is my contact information. And Melissa, I don't know if we have questions. I'm more than happy to take some questions.
Of course. I'm going to leave your slide up here with your contact information up for a little bit because there were a couple of people looking to figure out how to get in touch with you. So thank you for providing that. And thank you for a great presentation. That was very informative and really helpful. We do have a couple of questions, not too many, but if those who are attending do have questions, please feel free to either add them to the chat or to the Q&A feature, which can be accessed at the bottom of your screen in the toolbar. We have a question about someone who has post-herpetic neuralgia, and they've had it for over a year, and it's causing itching and severe tenderness on the head and forehead. They're wondering basically if the treatments that you described might be helpful with that, because this issue is really interfering with daily life and is just causing some real problems. So just wondering if any of the treatments that you've talked about might be helpful there.
Yeah, unfortunately, that's why I started with, the proper indications. And her post-herpetic neuralgia is unfortunately one of those things that is associated with some nerve damage. And all of this pain is this continuous pain. And the primary mode of treatment is medical. It is never perfect, but that's the primary line of treatment. It is not indicated to do a microvascular decompression or even a glyceral rhizotomy. Any of the ablative procedures are not really indicated in that setting. Perhaps sometimes this non-ablative options may be an option, but it's typically first-line treatment is medical therapy. There are options with neurostimulators, etc., but that requires an implant, and that's sort of down the line of trying things.
Absolutely. Okay, thank you. And then I have just a couple other questions. So do patient characteristics like age or I know that you mentioned some comorbidities and comorbid conditions that you consider, or even length of pain. Do those kinds of things, how do they influence basically your treatment recommendation when you're trying to balance the procedure's efficacy with its impact or potential impact on pain and then quality of life?
Yeah, that's an excellent question. So if someone we do everything we can to deliver the best possible treatment to a specific patient. So if someone has classic trigeminal neuralgia and they have vascular compression, even though they might be 90 years old, the best treatment for them is still a microvascular decompression. If done appropriately, I think that can be a very minimally invasive procedure. It does require general anesthesia. We have all our patients go through a clearance process where we have a center for preoperative care that evaluates them and gives them a risk assessment. So if they tell us that the risk of them undergoing, anesthesia is extraordinarily high, then you go down the list. But their age alone is usually not something that would preclude them from getting the appropriate treatment. We also, again, try and check everyone's hearing ahead of time. If someone's not having, if they have vascular compression but they can't hear, then there's a discussion. Or they have some hearing but they don't have the signals, even with the newer machines, even after exhausting everything. It's a discussion about, what's the most appropriate treatment, because if you can't monitor hearing, there is a chance that they may wake up deaf from this, although that risk is very low, again, with minimizing retraction, etc. If someone can't, let's say they had pulmonary embolism and they can't come off the anticoagulation, or they have severe heart disease that if they come off their blood thinners, they may have a heart attack. That may be a patient for Gamma knife, for example, even though it's perhaps not the most effective option. But that would also be the least life-threatening option by taking off their blood thinners. So it's highly individualized, but the goal is to always try and give the most effective treatment to a patient unless there's a reason for them not to get that. And then you go down the list. But we've treated multiple 80-year-olds and 90-year-olds with microvascular decompressions. There's been a paper out of this institution some time ago showing that it's safe. And if that's the best procedure, if they can undergo it, that's usually the best way to go.
Excellent. Okay, thank you. Are there any strategies or protocols, anything that you do pre or post-operatively that you've found significantly lower, like complication rates? I know you mentioned the CSF leaks and trying to minimize those. Anything else like that that can help improve recovery for people with facial pain?
So that's a very good question. I think we spoke about a lot of the technical nuances on how to decrease the chances of having any bruising or having any of that. Like a lot of that happens all the time. And then, it's not something that people would see. Like if someone has bruising in that cerebellum part of the brain, which is the part of the brain that's responsible for balance, they may not even have balance issues. They may have like some extra nausea, etc. So doing this in a way that's atraumatic as possible, is very important. So in terms of the protocols, everyone undergoes, as I said, a preoperative brainstem auditory evoked potential. So the test of hearing, not necessarily a hearing test, but is this test that we would use in the OR. So I want to know that we have that signal before we would recommend this surgery. Everyone undergoes detailed imaging that shows us exactly what is happening with the arteries and the veins before we go to surgery. So it's not, it's very common across many centers, perhaps less and less at this time, but it still happens if people have just classic trigeminal neuralgia, they just, book them for surgery. But having this very detailed, what we call either KISS or Fiesta sequences where we can show the nerves accurately is extremely important. I also get a CT angiogram before surgery that shows me the exact bony anatomy. And if these veins are running the bone, what we call the emissary veins, I know exactly how they look like. So I anticipate them. And the way that we deal with them is that we have to be very careful to expose them and then essentially reduce them down to this larger vein, what we call the sigmoid sinus. That's how you can get to the sigmoid sinus. We need to know, sometimes there's other little parts of the bone that we have to reduce, what we call the suprameatal tubercle. I need to know if there's air cells underlying that, if it's feasible to actually reduce that if needed. If it's not, then I have to work around it by perhaps using an endoscope. So there's several different small nuances that you want to be as informed as possible before you go to surgery, to know about these things and deal with them in a controlled manner as opposed to a reactive manner.
Excellent. Okay. And from a patient's perspective, we know that there's so many patients who continue, even with procedures being done, to have pain. So how do you see complementary and alternative therapies like pain psychology or acupuncture sort of fitting into the treatment plans for reducing overall that burden on patients?
That's another very good question, and we actually have a study ongoing right now about the post-traumatic stress disorder that's associated with having had trigeminal neuralgia. The issue with people that do have ongoing pain, of course, is to figure out firstly if there's anything reversible. So just like the example that I showed, just because someone underwent a microvascular decompression doesn't mean that they have their problem fixed. So it's important to have this evaluated perhaps by another practitioner to make sure that everything that could be done was done, and that the pain, is not reversible. Um, I haven't found acupuncture to be, very effective in patients that have, continued lancinating pain. And of course, the psychological effects that come with having this pain are very significant. But as long as the pain is there, then the driver for those is going to be there. So you can't just treat the psychological aspect expecting that the pain is going to go away, because it's just going to generate that again. So the entire effort in the beginning, I believe, has to go to how to treat the pain.
Mhm.
And once you treat the pain, then you can treat the side effects of the pain, which is the psychological implications that the pain had to someone's life. People are generally happy to get rid of the pain, but they do have a component of post-traumatic stress disorder that goes with it. There's still, I've had patients that they haven't had pain for a year, but they were afraid to shave because, they were afraid that the shaving is going to bring the pain back.
Mhm.
So there's a psychiatric slash psychological component to it that has to be addressed. But you have to take care of the pain first. I guess that's what I'm saying.
Absolutely. Okay, thank you. And we're just about to the end of our time today, but I want to ask one last question, which is, we always are trying to look forward and offer, hopeful outcomes, and having sessions like this is wonderful because you've really detailed the many different opportunities there are to mitigate this pain and to help people who are living with it. Are there any recent or emerging technologies, anything that's on the horizon that shows promise in reducing more of the surgical impact or the pain itself that you're aware of?
Again, we're constantly striving to make things like less invasive, to decrease our footprint. This is not something that we did and it stopped. We're constantly trying to see how we can make things better. I think what the future is going, though, is particularly now with AI, is hopefully trying to understand the disease better. I think one thing that is still really hard to treat is when you don't have a lesion, we don't have compression. What do you do? Again, we don't want to burn our cars by doing these lesional procedures, so that becomes more of an issue.
Mhm.
Um, I've actually been in touch with a group that is evaluating some newer medications that are old medications that are being repurposed. And that, of course, a lot of the old things stop being produced, so there's this challenges. But finding new pharmacotherapies for non-lesional trigeminal neuralgia, I think it's a priority, and it's a matter of active research. And there's a few medications that have been showing some promise, and hopefully will be available. But understanding the disease a little better, which currently, unfortunately, we don't understand it very well,
Mhm.
and going to the root of the problem, I think that's going to be key. And I think now we're hopefully going to be entering a new era in terms of understanding. We're very limited in terms of being able to understand. But
Mhm.
we're going to have tools right now that's going to allow us to understand a little more about our biology than we used to. And my hope is It's not going to be in the too distant future, but it's already happening.
Yeah,
Um, but the tools that we have are, really remarkable and something that we never had before. And I think my hope is that we'll be able to translate that into understanding trigeminal neuralgia better too.
absolutely. Well, Dr. Zanonos, I want to thank you so much for being here today and for sharing your expertise with us. I'd also like to thank everyone who's attending for taking the time to be here with us this afternoon. Please don't forget to participate in the facial pain registry, and you can look for a recording of this webinar on our website and on our YouTube page next week. All of that, all except for the YouTube page, but our website is www.facepain.org. Again, thank you, Dr. Zanonis. We really appreciate your time.
Thank you very much. Thank you for having me.